morning to everyone. My name is Daniel Motta, and I'm a member of Group 6 Prospectus team, and I'm delighted to present to you the project titled The Effect of Memantine on Quantitative EEG in Pediatric Patients Non-Responsive to Standard Treatment for ADHD, a Phase 2 double-blinded, placebo-controlled randomized trial, the Me-ADHD trial. We declare no conflicts of interest, and I would like to begin to explain what was our motivation to research on attention deficit hyperactivity disorder. So ADHD is a high-impact neuropsychiatric disease worldwide. In terms of prevalence, it is estimated that 1 out of 20 kids will suffer of this condition during their childhood. Additionally, ADHD greatly impairs the quality of life and functioning of those kids who suffer the disease, and it accounts for a significant economic impact to health systems due to its chronicity and prevalence. One of the aspects that caught our attention the most, and is actually the foundation of our study, is that from 16 to up to 50% of patients will not respond to standard treatment for ADHD. This might be explained due to a lack of efficacy, the side effect profile, or social stigma that has been growing in recent years in not giving stimulants to children. So we ask ourselves the question, so what can we do with this? So we consider that there is a need to develop new drugs with different mechanisms of action that may be helpful for these non-responsive patients. So ADHD is characterized by a persisting pattern of impulsivity, hyperactivity, and inattention. These symptoms have been classically explained by an increased concentration of dopamine and norepinephrine in the synaptic cleft. So the current treatment for ADHD relies on increasing the concentrations of dopamine and norepinephrine in this synaptic cleft. So we have two medications. We have methylphenidate and atomoxetine, which will block the reuptake of these neurotransmitters in the presynaptic cleft, and therefore will increase the concentrations in the synapse. Recently, it has been proposed other types of pathways, such as the glutamate pathway, that may explain the pathogenesis of ADHD. So what happens and what has been hypothesized is that there is an increased activation, or there is a hyperactivation of the glutamate pathways in ADHD. So if one is able to block the receptor of glutamate, one might be able to decrease this hyperexcitability and neurotoxicity that glutamate is exerting in these pathways. So there is actually a medication, a drug called memantine, that is going to block that receptor, which is the NMDA receptor in the postsynaptic neuron. Taking into account this, in order to explore the possibility of memantine being a possible alternative treatment for ADHD, we did a literature review on the existing knowledge, and we found that preclinical studies in rat models have shown an increased activity of glutamate receptors that has been demonstrated in the prefrontal cortex of these animals. When we examined which were the phase 1 studies, we found that 26, if one does a search in PubMed, one can actually find up to 26 studies in which the intervention was memantine in children for other conditions. And these studies actually proved to be safe. Actually proved that memantine is safe and tolerable in this population. Then we wanted to know what has been done regarding phase 2. So we found that Mohamdi and collaborators in 2015 compared memantine against methylphenidate to control the behavioral symptoms in ADHD. Mohamdi and collaborators found out that memantine is safe and tolerable for this ADHD population of children. However, they found that methylphenidate was superior to memantine. We also have evidence of that quantitative EEG, or quantitative electroencephalogram, could be a possible surrogate for ADHD. So if you see in this slide, in the construction of new knowledge, there is a gap here. Mohammed and Al and other investigators just skipped one part here that was actually to compare memantine against placebo, and they just went straight to compare against the standard treatment. And this is what we want to fill. This gap is what we want to fill with this protocol. Taking into account the former, we propose the following research question. Is there a difference in quantitative EEG as indexed by the theta wave frequency during a 12-week treatment with memantine versus placebo in children with ADHD not responsive to a standard treatment? So we designed a superiority double-blinded multi-center placebo-controlled study that aimed to measure as a primary outcome the quantitative EEG as indexed by the theta wave frequency. So following the Declaration of Helsinki, it is imperative to highlight that we justify the use of placebo in this trial, taking into account that withdrawing the medication in these children will not actually lead to harmful permanent effects. And also the short period of our study can also justify the use of placebo. We plan to do a randomization using a random size block randomization and doing stratification by site center since we're going to use 2 site centers. We are going to do the unallocation concealment based on a central online randomization service. Regarding blinding, this is a double-blind study, so no physicians, any staff member, assessors, patients, guardians, or parents will know the treatment allocation. In the case of severe side effects, as assessed by the clinician and other specified criteria we have in our manuscript, unblinding may be possible. Regarding the eligibility criteria, we're going to include children from age 6 to 11 that have met the DSM-5 diagnostic criteria for ADHD, but additionally they are not responding to the primary line of treatment. We are going to measure this by having a 30% or less decrease in the SNAP-5 criteria scale, or 2 or more points in the GCI, in the CGI, in GCI scale. So what these scores do is they just quantify, they just determine which patients are responding or not responding. Also, we're going to include those who were not responding due to the lack of tolerability or because they were uninterested to continue with the primary line. Regarding exclusion criteria, we're going to exclude those patients with a history of current psychiatric disorders, neurological disorders, or any other chronic medical conditions as specified in our manuscript. Regarding recruitment and adherence, we're going to do a broad recruitment strategy using public advertisements, but also we are going to recruit children as referred by the child psychiatrist. Regarding methods to enhance adherence, we are going to provide snacks, transportation, ludical activities while the children are in the facility. We are going to explain parents using some brochures, and we are also going to have scheduled appointments every 2 weeks to ensure this. Regarding assessment of adherence, we will do a pill count every 2 weeks, and also we'll give to caregivers a diary so they can register if these patients are not compliant with the trial. Regarding the outcomes, we are going to assess as a primary outcome a surrogate outcome, which is the quantitative EEG. So what the EEG does, it registers the brain activity as the function of some waves. So we want to assess the frequency of specific type of wave, which is the theta wave. And in that way, we can assess whether or not patients modulated their activity in the prefrontal cortex as a marker of ADHD improvement. We are going also to use as a secondary outcomes measurement scale called TOVA. So TOVA is a neuropsychological test that objectively measures a response time of pressing a button to some visual stimuli and some auditory stimuli, which can also be a marker of attention, which we know is impaired in this population. We will also want to include a clinical outcome, which is the ADHD 4 score, difference. And what this course does is going to assess the behavior disturbance in these patients as a clinical outcome. Regarding the timeline, so our study is divided in 6 periods. Each period comprises 2 weeks. We will do measurements of EEG, TOVA, and ADHD4 at baseline and at the end of the study. And we will also do EEG and TOVA for each of the periods of our study, that is every 2 weeks. Also, in this chart here, you can see the increases of dosages that are going to take place in period 2, 3, and 4. And the idea of increasing dose is to take these children to the maximum safe dose as reported by the literature to try to increase the effect size of our study. Sample size calculation was calculated using standard parameters, 80% power, 2 alpha level of 0.05, and an effect size difference of 0.65 as reported in the previous literature regarding the difference of the frequency of the theta waves in the EEG. We calculated a sample size of 78, and assuming a dropout of 10%, we had a final sample size of 86, 43 in each group. We will perform as a primary outcome analysis a independent sample t-test comparing the difference in the EEG theta index from baseline and at the end of the study. And the secondary analysis of that primary outcome, we will also want to do a repeated measure ANOVA, because remember, we are going to do this EEG every 2 weeks. As a secondary outcome analysis, we will also use the repeated measure ANOVA for the difference of the ADHD4 score and for the difference of TOVA, since these are quantitative variables and are going to be measured every 2 weeks. To control for missing data, we will use modular imputation methods, assuming missingness at random, and we will also want to perform a sensitivity analysis in terms of intention to treat and per protocol analysis. I just want to address some limitations of our protocol. Even though it has been suggested that the EEG is a surrogate for ADHD, we might need more information regarding the surrogate. Also, there is lack of knowledge of the disease of the pathways of the disease. We still need to know more biological basis. And well, those are the main limitations. Thank you very much for your attention. I really wanted to thank Dr. Fregni because this project had a 360 spin in the past 4 days. And I also want to thank Marcos, Stefano, and Ines. They were really good TAs in helping us with this project. And of course, all the amazing Prospectus team members. You are great, so thanks.
Okay, so a quick comment from the audience. All right, so any comments here from the faculty? That was also my group as well, so I just quick testimonial. So yes, we did change a lot. And what we changed, and you may not notice now seeing the final product, was the challenge. So they wanted to develop something new for ADHD. They were convinced that this drug had an effect, but the only small trial showed that the standard drug was better than this drug. So what should do then? So then they had the idea, so let's get the non-responders. Let's also then compare against placebo. Let's also use a surrogate outcome. So that was the sort of the development here. You see, so they really thought of several sort of potential designs and got to this final design. So it's great work. I know you guys spent many evenings together working on that. Congratulations.
Thank you.